Hello, everyone. Welcome to another Monday Rafael Medina subspecialty. Today we have pulmonary and critical care. We have a really special guest that the CPS oversees. Really big fan of her. We have Dr. Basak. She is a pulmonary and critical care physician and medical educator. She is a program director in the University of Washington, and she brings today two guests for us from the Pulmonary and Critical Care Fellowship, Dr. Mira and Dr. Laura Granados. Do you all want to say hello? Tell us why did you choose pulmonary and critical care?
Sure, I can
Laura,
go first.
yeah,
Hi everyone. I'm Mira. I'm one of the senior Palm Crit fellows. This is my, I think, second time on here. Glad to be back. Why I chose Palm Crit, where to start? I love the physiology. I love all the medicine. I love the interesting cases, the combination of ICU and pulmonary, the teamwork, the interdisciplinary care. I could go on.
Great. I'll go next. I'm Laura. I'm a second-year fellow, and this is my first time here. Thanks for the invitation. I chose pulmonary critical care for some of the same reasons as Mira. I love the physiology. I love that you get to be a generalist, but then also specialize. And I think that the mentorship too played a big role, because I could have gone into cardiology for the physiology, but I had awesome mentors during med school and residency. So that's why, I decided to do pulm crit care.
Awesome. Thanks for the invitation to come back. I think I'm especially proud to come back with two of our amazing senior fellows, both of whom are educators in our division. I will echo all the things that have already been said. I think if I had to highlight kind of three of the things about pulmonary and critical care that get me out of bed in the morning, I think the physiology piece is one. I think a really big part of it is the team-based care. I think it's really unique that we round with and care for patients with physical therapists and respiratory therapists and skilled ICU nurses. And I think being a part of that team is really gratifying. And then I think a really big one for me is a lot of the end-of-life care that we provide in the ICU. We care for people at a really vulnerable time in their lives. No one wakes up and plans on being critically ill and in an ICU. And I think we have a lot to say about how that time goes for them. And sometimes we can't get them better medically, but we can care for them in other ways. So I think those are the three that I would pick.
Amazing. Thank you so much for these amazing answers. And I think Laura, Dr. Laura Granados, sorry, we can start with the case.
Sorry, I was muted. I said that sounds good. So I'm going to be telling you guys about a 52-year-old woman who you are meeting in the hospital, in the ED, for shortness of breath in the setting of some subacute diarrhea, and what people had been calling failure to thrive. So she tells you, she comes in with her daughter and husband, and they tell you that she had been doing okay, but then for the several past weeks, she was developing some shortness of breath, presented to an outside ED, was diagnosed with a bacterial pneumonia, and she was treated for community-acquired pneumonia with antibiotics. Her symptoms did not resolve after completing treatment, and then she presented to her outpatient doctor, and she was noted to be very sick, and I can give you more details, but just vital sign abnormalities, and just appeared ill. So she was asked to go to the emergency department. In the emergency department, she endorsed shortness of breath on ambulation. She said that she'd been having a chronic cough. She also tells you that she's been having diarrhea for months now, multiple bowel movements a day, about 5 or so. And then should I give the, because this is my first time doing this, should I keep going? Should I wait for people to ask for questions?
I think we have a good start here. We can ask Dr. Mira John if you want to start and give your thoughts about this presentation.
Sure. Okay. 52-year-old woman coming in with diarrhea, progressive shortness of breath, and overall failure to thrive. Any other symptoms that she reported? Chest pain, shortness of breath at rest, anything about the diarrhea? Was it bloody, non-bloody?
So non-bloody diarrhea, kind of watery. And for the shortness of breath, like associated symptoms, she didn't have any chest pain, but she was describing some orthopnea, having more difficulty when laying flat as well.
Okay. Interesting. How long had that been going on for?
That had been going on for about a week.
Okay. Any lower extreme swelling in her legs?
So not that she endorsed, but later on you'll see that she did have some
right.
her legs.
Okay, interesting. Abdominal distension?
None.
Wheezing?
No.
Rashes, facial flushing?
No rashes, no facial flushing.
Okay. I want to ask more about like medical history, medication, those things, but before moving to that next section, Basak, do you have any questions that you want to add?
I have so many questions. Maybe I'll let
I do too.
Lara, I'm going to let you reveal some of them. I think at first blush, the things I would say. So it really sounds like this is more chronic diarrhea as kind of an initial symptom going on for months, and then more recently, shortness of breath, and then a chronic cough as well. So I think just hearing that, the differential is so broad. So maybe we can find some multi-system way to connect these things, and maybe we're dealing with something inflammatory. So inflammatory bowel disease. It's a little late for a 52-year-old, but it's definitely possible. It has a bimodal peak. So you could have inflammatory bowel disease with associated lung disease. It could be that this is something infectious. So lots of viruses can give you diarrhea. I wouldn't expect 5 months of that. We'll have to hear more about what are her risk factors for unusual infections, if she has any, is she a normal host or is she immunocompromised? Or is this something like rheumatologic, again, that would tie in multiple symptoms? So I think we need a lot more information before we can proceed. So maybe you can tell us a little bit more about who she is as a host, and then we can go from there.
Perfect.
I want to also add to this, in addition to other inflammatory things, I'm also wondering, could this be, again, given the progressive nature of this, some type of malignancy, malignancy tying everything together, carcinoid was the one that jumped out on my end, or something else entirely. But yeah, I think we need a lot more information in the meantime.
Great. So she has a history of malignant mesothelioma. She was diagnosed, and it's of the abdomen, it's not of the lung. In fact, she had a pleural biopsy that was completely negative. So she's undergone significant treatment, and she has had several courses of chemotherapy and immunotherapy, and I'll give you the specific medications. And there's concern for disease progression at this time. You learned that from the Seattle Cancer Care Alliance notes. So she was initially treated with ipilimumab and nivolumab. She has also received carboplatin, paclitaxel, and bevacizumab. And after that, there was noted, again, disease progression. So she's currently on a study drug. That means nothing to you, so you look it up. And you learn that it's a polyamine mimic. And that's basically her past medical history. She doesn't have any other end organ dysfunction that you know about or that has been documented.
Okay, I would say that changes our differential a lot. So when I was thinking about immune system, I was thinking, HIV and chronic diarrhea, but this is someone that has a different form of immunocompromise. And what we've heard is she has an underlying malignancy that we know is usually related to serosal surfaces. So you said it's in the abdomen, not in the pleura. I don't know if that could necessarily explain the 5 months of diarrhea. I think that seems less likely, but I think when I'm caring for patients with cancer, my questions are, is this related to their cancer? Is this related to their cancer treatment and their chemotherapy? Or is this an infection and something she's at risk for because of her cancer-directed therapy? And you named a number of agents, so immunotherapy agents, ipilimumab and nivolumab. And then of that list, paclitaxel is a taxane that can cause pulmonary toxicity. The immunotherapy can cause toxicity in the lungs, but really in any organ, and that piece maybe could tie in the diarrhea. You're going to have to teach me about polyamine mimics and what that puts someone at risk for, because I have no idea. And then I think, again, infectious things are definitely in the differential. So this is someone where we're going to want to think very, very broadly.
Anything that you can hear?
I don't have anything to add, except I too am unfamiliar with polyamine mimics, so ready to learn.
Yes, and I'm trying to look where I wrote what I learned about it, and I'm not finding what I wrote, and I apologize in terms of the mechanism of action. Let's see if I can find it. If not, I will have to move on, and then maybe later we will find it.
Yeah, that sounds okay. And while you're looking for that, Laura, there's a great comment in the chat from Jimena about thinking about a heart failure component due to the chemo agents, which is a great thought. Again, given all of the agents, some of these can cause cardiotoxicity. And certainly patients with heart failure can present with cough and shortness of breath on exertion. And so we didn't hear about things like lower extremity edema or orthopnea, but those are going to be things we'll want to look for on exam. Is there anything that supports cardiac cause of her shortness of breath?
Yeah, so she did have orthopnea, and
she did. Okay.
You may find out that she does have lower extremity edema. But yeah, I will try and look for the explanation of the mechanism of action of polyamine mimics, because I did look it up, but I can't find it right now. But would you like to ask any other questions about her presentation?
I think the other things I would want to know about at this point would certainly be around things like exposures, and we're going to find out more about. I think it's still really broad, but whenever I hear about someone who's really immunocompromised, I want to think about, are they taking prophylactic medications to prevent certain infections? Have they been taking those medications regularly? So a little bit more on kind of her med history and medical history. And then I think all the usual things about, when someone has chronic cough. So thinking about, the top 3 reasons people have that are usually related to GERD or upper airway cough syndrome, or could this be undiagnosed asthma? So taking a really good history and not kind of anchoring on an immunocompromised host that might be at risk for infections.
Yeah, so she is on Bactrim, acyclovir, but no fungal prophylaxis. It was not indicated by her oncologist. And then other than that, she just takes a statin. I can tell you in terms of family history, there's no notable family history. And then in terms of social history, she hasn't worked, she's been ill for multiple years now. She used to have a desk job. She was born in the Seattle area and has lived in the Seattle area. No recent travel into other areas in the US or outside of the US. Has not experienced any homelessness, has not been incarcerated, was checked for HIV, initially before her cancer was diagnosed, and then during treatment, and it was negative. There's no exposures in her hobbies to know of, and then she doesn't have any pets at home, no birds.
Did these symptoms, is there any relation to like when any of these symptoms started and any changes to her treatment regimen for her mesothelioma?
No, that's a very good question. No, so she was started on the polyamine mimic recently, within the month or so. So yes, then her dyspnea would be related to that change, but not immediately after the change, if that makes sense. And then the diarrhea has been present since before then.
Okay.
And then Laura, how about the timeline from exposure to the immunotherapy to the onset of her symptoms?
Yeah, so she was exposed to immunotherapy first in January of 2022. And then the last time she received any immunotherapy was in April of 2022. So it's been a while. And then
I'm sorry, when is this case? I didn't hear when this case is from.
yes, because I didn't tell you. This case is from probably a couple months ago.
Okay, so over a year since immunotherapy has ended. Okay, that's really helpful information. Usually toxicity from immunotherapy can be variable and can start early, but for pulmonary toxicity, we generally start thinking several months out from immunotherapy. And I'm sure there are reports of going beyond a year, but past a year, that starts feeling less likely that it's related to the immunotherapy. So I would wonder if perhaps we need to think more about this study drug, if it's even medication related.
Yeah. Yeah, and the Taxols, those were, she received those in 2020.
And she was switched from all of these, not because of side effects, but because there was progression.
Yeah,
Okay.
she progressed through, the different therapies.
And Dr. Basak, we have a question, like in this situation, there's any kind of infection that you could be more concerned about in this patient?
Yeah, great question. So I think it's going to depend a lot. I think that the first thing we need to get is a really good exam and getting a sense of the imaging, because I think ultimately, especially in immunocompromised hosts, the imaging really helps narrow down our differential, where we go from it could be anything to then using the radiographic patterns. I will say, in hearing how long these symptoms have been going on, these have all kind of been chronic symptoms. And in normal hosts, when we hear of it's something that's been going on for months, we tend to think of more, could this be fungal or parasitic or less likely bacterial, and sometimes even viral. But in immunocompromised hosts who often never clear viruses, it's absolutely plausible that this could be a viral infection that explains both what's going on in their lungs and the diarrhea. And she just is unable to mount an immune response to clear that infection. So I think at this point, I don't know that we can narrow things down until we get some more information from our exam, and then can importantly look at the imaging.
Yeah, I agree. I'm interested to hear about the exam.
Great. And just because I see that there's health related behaviors. She doesn't drink, doesn't smoke, hasn't ever smoked, no recreational drug use, and then no known allergies. So when you meet her, her temperature is 38.3. She has a O2 sat in the high 80s at rest, and then when she goes to the bathroom, she desats to the low 80s. It corrects with about 4 liters nasal cannula. Her blood pressure was initially 87 over 68. With a low MAP, lower than 65. She received some fluid and her blood pressure initially corrected, but then despite fluid, she continued to have MAPs below the 60s. Her exam. So she appeared ill. She was very thin. Her lungs, she didn't have any wheezing on auscultation, but there were a little bit of crackles at the bases bilaterally. She was somewhat tachycardic. I believe it was like to 120s. It appeared regular. There were no abnormal heart sounds otherwise. She had, I would say, 3+ lower extremity edema to the knees bilaterally. Her abdomen was soft, non-tender, and non-distended. No skin rashes. She wasn't very cold. She was warm and appeared to be, despite her low blood pressure, perfusing okay, and maintaining okay. Anything else that I didn't tell you about the exam that you are wondering about?
So
Do we talk about neck veins, Laura?
Yeah, so her neck vein was elevated.
Okay.
Yeah, yeah.
Okay, so to summarize, she's febrile, tachycardic, hypotensive, potentially in shock if she is not responding after, or if her blood pressure is not improving after appropriate resuscitation, hypoxemic, and very ill appearing. Yikes. Be curious to hear more about initial labs and imaging.
Perfect. I'll tell you. Oh, sorry, Basak, you can go ahead.
No, I was just going to add one more thing here, which is that I think one of our jobs in the ICU is to make a very quick assessment of, I mean, as in every field, we do an assessment of sick or not sick. But I think in the ICU, we're making an assessment of sick, and is this someone that's going to need, additional potentially life support sooner rather than later? And she sounds like she's in that camp. What you've described as someone, so I think one crude way of looking at it is looking at the shock index, which is the heart rate divided by the systolic blood pressure. And ideally that should be like 0.5 to 0.7. And if that ratio is greater than 1, that's concerning. And her heart rate's 120 and her systolic is 87. So that alone is, I think, concerning. She's also febrile, which is going to push us to think a little bit more, I think, about infectious complications, although some inflammatory conditions can give you fever as well, like organizing pneumonia, for example, in the lungs can be non-infectious and give you a fever. But I think we'll definitely want to think more about that. And then I think what you described with her edema and her neck veins being elevated is really striking. And combined with her history of having orthopnea and these exam findings, this is someone where I would want to do a bedside ultrasound and echo sooner rather than later, because it certainly sounds like she may have a cardiac component to what's going on.
Great. So she, and I'll give you all that data, but starting with labs, her CBC, she had a white blood cell count of 5, hemoglobin of 8.4, and you look back and that's her baseline. Her platelets are 121, also around her baseline. For her BNP, her sodium is 128, her chloride is 100, potassium of 4.5, bicarb of 22. Her glucose is in the 90s, BUN of 15, creatinine of 1.6, and her baseline is around 0.8. Her ICAL was 1.3, her MAG is 3. Her AST, her hepatic function panel is all normal. I'll just say that. And then she has a lactate of 1.5. Are there any other labs that you would like?
Since we are concerned about cardiac sequelae or etiologies, do we have a troponin or a BNP while we are grabbing the ultrasound to do a POCUS?
Great. So her BNP is in the 500s, and her troponin on initial check was 1, but because of the suspicion was high, it was rechecked anyways, 3 hours later, and it was 9 on recheck.
Okay, that's super interesting. So I think in some ways, there are some things in her labs that are a little reassuring and then some things that are worrisome. So Mira alluded to this already. I think one of the things we're thinking about as intensivists is this person in shock or not? And, low blood pressure doesn't, my blood pressure is actually probably close to 87/68 right now because I'm so relaxed. But I am not in shock. And I think this person is, because we've heard that she's doubled her creatinine. So she clearly has evidence of end organ hypoperfusion, even though her lactate's actually not that elevated. And her bicarbonate is actually pretty close to normal, but she clearly has some markers of shock. So that part is worrisome. I'm reassured that at least her liver function appears to be normal, and that's one organ system that's not involved. I will say that troponin is really high in our lab. So I realize there's different labs and there's high sensitivity troponins, but in our lab, less than 0.04 is normal. So hearing that a troponin is 9, that's quite elevated, and makes me wonder about things like myocarditis. She could have a primary cardiac event, but when you hear of something that elevated, I would keep kind of an infectious myocarditis on the differential as well. And I still really want to see the echo, as does Mira.
Great. She also had a respiratory panel that was negative, for what it's worth. Okay, so you do a POCUS, and on your POCUS, you see a dilated right ventricle that appears to be squeezing okay, though it's dilated. And then the LV is barely moving, and you think that maybe the ejection fraction is around 20 or so. The most recent echo that you have for comparison is from about a year prior, and it was completely normal at that time. And then you do get a formal echo if you're interested in that data as well. So they confirm that there's right ventricular dilation with mild systolic dysfunction of the right ventricle. Her LV is severely the ejection fraction is severely reduced at about 15%. There's no valvular abnormalities. And then her right atrial pressure is estimated at about 5 to 10, so not that elevated. But her PASD is about 45. And then there's a small pericardial effusion.
I think someone else asked about this in the chat, but are these findings, do we have any prior echoes in her system? I'm guessing all of this is new.
Yes, yeah. So I mentioned that the one you are able to compare it to was from about a year prior, and this is all new. So you don't know how new, but you know.
Yikes. This hasn't narrowed down my differential too much. And besides, like, okay, there's some type of cardiac component involved. I too am worried about a myocarditis picture given the question mark infection, but still trying to keep a broad differential. Since the troponin did go up, I am curious if there were EKG findings associated with it. But as a budding pulmonologist, I'm also interested in the imaging.
Yeah, so her EKG had non-specific SCT changes. I apologize, I didn't grab it. That were somewhat diffuse, and then but no signs of acute coronary syndrome. And then let me see if I can share the CT with you.
Great. And while you're pulling that up, Laura, I think this is I think the fun part of critical care where we don't always go sequentially. I think this is a setting where we want to be kind of doing diagnostic things while we're doing therapeutic things, because she's super sick. And I think on the diagnostic end, so we're going to look at imaging, which will be helpful. I think we'd want to get cultures of kind of everything, certainly of blood, sputum if she has any. And then I would want to do a full enteric pathogen panel, not just testing for C. diff, because she's immunocompromised and could have, unusual types of, parasites or other infections. And then starting her on broad spectrum antibiotics, even before getting all of this data, I think she just sounds very sick, and we're concerned about septic shock being the source of shock. And Jasdeep, I completely agree, checking for HIV as well. I suspect she's been screened for HIV prior to getting chemotherapy, but that would certainly change our differential again. And then this is also a time where even without ischemic changes on her EKG, given the cardiotoxic chemotherapy that she's gotten before, and this question of could this be something like a viral myocarditis, or could this be toxicity from the study drug causing this cardiac problem, early engagement and collaboration with the cardiologist.
Great. So let me show you the CT. So this was a CTPE. And I just have some cuts. I'll pause a little bit on each, and then I'll keep going. Let me know if I'm going too slow, too fast.
Perfect.
That's the last cut that I have.
Mira, do you want to start? Or do you want me to?
Yeah, no, this is fascinating. So my immediate thoughts looking at this scan, independent of everything that we know so far, I'm seeing many nodules and what appears to be a random distribution. I'm trying to scroll up again, pay attention again as we're scrolling up, of different sizes as well. There is a broad distribution for that. Includes septic emboli, malignancy. Those are the two things that jump up to me immediately. I do see it looks like she has pleural effusions bilaterally, right more than left. If we were looking at the imaging real time, I would check on the abdominal windows again to see, in the same imaging to make sure it is an effusion. Basak, what would you like to add to this? I mean, there's a lot we can go into here.
No, I agree. I think the striking things are, these are, I agree, randomly distributed nodules that are quite dense. And seeing that distribution, I would worry actually most about malignancy. I think the only thing that sways me away from malignancy is that some of them are really irregularly shaped. And one of the things that's very classic for metastases in the lung is they tend to be like very smooth and perfectly circular. So I would want to know has she had these nodules before? Does she have known metastatic disease? And is that what we're looking at? Or are these new? When you see nodular lesions in immunocompromised hosts, the other thing that I think about is, could this be a fungal infection? And that tends to be where we see the halo sign, where you get kind of a dense opacity with surrounding ground glass, and that surrounding ground glass represents hemorrhage around and usually related to an invasive fungal infection. This doesn't have that type of appearance to it. So again, would want to hear more about, are these all completely new? And then agree that there's relatively large bilateral pleural effusions. Just based on the scroll, they look like simple pleural effusions. Laura, you can let us know if the radiologist commented differently, but this kind of fits with everything you're describing on your exam, with heart failure, the 3+ pitting edema that you saw in your exam. Usually in the setting of bilateral pleural effusion, someone made a note about, maybe we should tap those. Usually in the setting of, gosh, this just looks like heart failure, we usually don't, because we diurese and that's how we manage the volume. I think in this setting with someone who's febrile, it's not unreasonable to perform a diagnostic thoracentesis. I think that would be further down in terms of my steps for management for this patient, but I think it's a reasonable thing to consider.
Great. So you compare it to prior imaging. She obviously has prior imaging, and most of the nodules had been there. They were felt to be metastases. There's an area that appears, this area over here is somewhat new as compared to prior. It was a little bit more ground glass, and prior was about 4 months ago. or soap. And so it used to be a little bit more ground glass, and now it's a little bit more solid.
Interesting. So differential for, I guess, new ground glass in the setting of malignancy, again, is broad. It can be infection, it can be fluid, it can be progression of her underlying malignancy, it could be a side effect or complication of any of her various treatments. I'm trying to think of something that could link all this with her cardiac thing, and I'm wondering if I'm anchoring a bit too much. Basak, what are your thoughts?
Yeah, I completely agree with your differential, Mira. I think it's still really hard to know at this point how much all three of these things are related. I think we can imagine a place where someone has a cardiac event, whether that's cardiac toxicity from their chemotherapy or the study drug, and then develops volume overload and gets these bilateral pleural effusions. Maybe that's like a patch of pulmonary edema there. I don't know how to tie in the diarrhea with that unless we're also saying that's a complication from this drug, which is plausible. I think this could also be a, so we said broad differential for infectious things. This could also be non-infectious. So maybe we're looking at, it's not a classic appearance for organizing pneumonia. I'd expect to see it in a few different places, but this could be something non-infectious in the lung as well. So I think priorities right now, I think first priority, I think what's driving much of her illness is her heart right now. So I think kind of her heart failure management needs to be kind of the primary thing that we're doing while we're looking for infections that are GI related and also covering broadly for potential bacterial pneumonia.
And supporting her in the ICU in the meantime.
Yeah.
Okay, so would you put her on pressors, and if so, which, and would you diurese? Is that what you're getting at?
I think if she has remained hypotensive despite the appropriate fluid resuscitation, yes, I would start her on pressors. My go-tos are norepi as my first line. Norepinephrine.
And I think it's tricky right now because she seems like she has components of both potentially cardiogenic shock, and then she has a fever and she's immunocompromised. So there could be a component of this that's just distributive as well. What you've described based on the echo, Laura, it doesn't sound like her right atrial pressure is terribly elevated. She clearly has signs of volume overload with bilateral effusions and edema, but at least those numbers are reassuring that we don't have to diurese immediately. So that's a good thing. So I think I would also start out with just hemodynamic support for now. I think another important thing, just stepping back a little as we're doing all of these diagnostics and therapeutics, is this is someone who it sounds like has a life-limiting illness with disease progression despite several different agents. So while we're doing this, I think it's also important for us to be talking with her and then with her family or her loved ones about kind of what her wishes are, because she's in multi-organ failure right now. She's very critically ill. So I think getting a sense of what are her values and preferences around care would be important at this point too, before we start talking about much more advanced therapies.
Yeah. So we continued, we talked with them, and we continued the diagnostic workup to at least have a sense of what we were dealing with, and then better, guide them through those decisions. We involved the cardiology team, and they recommended a cardiac MRI. The concern was that, as you both alluded to, that a lot of the things that she was presenting with could be tied by maybe a checkpoint inhibitor toxicity, multi-organ toxicity. Though the timeline didn't quite fit, you all also alluded to that. The study drug is so new that it doesn't even have a name. It's like one of those that has a little number. And there's no a lot of data on whether or not the symptoms could be related to that medication. So we were left wondering. So for the cardiac MRI, she had, they confirmed what we already knew in terms of her severely reduced systolic function, and right ventricular dilation. She had subepicardial enhancement involving the basal to mid-lateral wall segments and myocardial edema. It didn't mean much to me at the time. I had to rely on our cardiology friends, but does that mean anything to you guys?
So I don't know that that necessarily means anything to me, but it does make me worry more about drug toxicity. I think, I don't know that that's what I would expect in the setting of myocarditis. And I think the reason the distinction is important is that if we think that this is toxicity from immunotherapy or a study drug, the treatment of choice in that setting is usually high doses of steroids if we think this is something really inflammatory. And that's worrisome in someone who's very immunocompromised, who's also febrile, and we're wondering if there's a component of infection. And there's some infections, particularly a few viral infections, where we'd worry about things getting worse in the setting of immunosuppression. So I think this is where we would want to have a multidisciplinary meeting with the oncologists who are the most familiar with this drug, recognizing that no one is really familiar with this drug, and then the cardiologists and their interpretation of that MRI.
Great. So we, treated her with broad spectrum antibiotics. We supported her blood pressure. When she no longer needed blood pressure support, we started diuresing her some. Her infectious workup was negative. Blood cultures were negative. Viral respiratory panel was negative. We did bronch her, and that showed lymphocytic predominance in the cell count, and the infectious workup was negative. The cytology showed that there was some abnormal cells consistent with her known mesothelioma. And so the thought at the time was that this was most consistent with a myocarditis. Her troponin peaked at about 15, and she was started on 1 gram of methylpred times 3 days, and then she had an ongoing high dose for a while. She was able to make it out of the hospital, which was reassuring. Yeah.
And now, just to clarify, so they thought it was an inflammatory myocarditis related to the study drug and not an infectious myocarditis.
Yes, that's
okay.
And she had, colitis, like a checkpoint inhibitor colitis. And the thought was also that maybe some of that, what used to be a ground glass area that then became more consolidated, could have been a pneumonitis. We would have not done anything different for it, since she was already getting steroids for the myocarditis. Yeah.
That's fascinating.
Incredible. And did her cardiac function recover?
So we haven't checked yet or I guess, there was a recheck on discharge and it hadn't recovered, but interestingly, she wasn't as sick as when she came in, obviously when she discharged, even though her heart function had not recovered as much. So maybe just like getting her on the better curve of the Frank Starling curve with like diuresis was enough. But yeah, we haven't checked again since. It's been a couple of months since discharge.
And it sounds like, to Austin's point, if all of the infectious workup was negative in the end, the fever was also attributed to, it sounds like, massive inflammation in multiple organs.
That's correct. Yeah.
Wow, that's an incredible case.
Yeah, I'm glad she did well in the end.
And I think what I would say about this is, so I spend actually a lot of my time in an oncology ICU. Laura, I don't know if that's why you picked this case or not. I'm guessing that's where this is from. I think this is always the question when someone comes in with these symptoms. And I think the framework is always start with, is it their cancer? Is it their cancer treatment? Or is it a really, long list of potential infections, and concurrently working those things up and potentially treating them at the same time? And I think a really nice example of, the odds we come to when the two things on our differential are something inflammatory and something infectious, and we have this question of do we treat with steroids or not, which might make one thing better and might make the other things worse. I think this case really nicely highlights that.
Amazing case. Thank you so much, Dr. Laura Granados. We want to know if you have some teaching point from this case. What did you learn and wanted to share with us?
Yeah, so I think the main learning point for me was I'd never seen a case of checkpoint inhibitor myocarditis. I once heard that the presentation in terms of timing can be a little bit variable. There's a timing that we keep in our minds, or a timeline that we keep in our minds when we're trying to decide or weigh how likely it is that it's a checkpoint inhibitor side effect. But I think this case was also a reminder that even though we have those timelines, the patients don't always present in the way we expect them, was number one. And then the other, I think, teaching point that or thing that I learned from it was she appeared ill, but not as much as I would have expected for someone with that echocardiogram. When she had the ultrasound, I was very, and I was hoping to show it to you guys today because the LV was barely moving, and that was impressive. That I think in someone who has the physiologic reserve, because she was a cancer patient, but otherwise didn't have any other organ damage before this, they can survive something like this really bad myocarditis. That may be another patient who could have had multi-organ dysfunction before would have not done as well.
Amazing. Thank you so much. And Dr. Basak, actually, I have a question for you. When we had the CT and we saw Granados, we think about some differential for the patient that was immunocompromised. And when we don't have immunocompromised patient, what differential we could think about when we see nodules in the CT? Just a little thought.
Yeah, sure, Deborah. I think just like Mira said, usually what we think about is one, how are the nodules distributed? So what size are they, and do they seem to be, and we'll divide them up into is it kind of a random distribution? Is it a hematogenous distribution that's really where we worry about metastases or invasive fungal infections, or septic emboli? Those are all things that are traveling through the blood, and so they'll give you kind of a hematogenous distribution. Are they in upper lobe versus lower lobe, et cetera? And there is a pretty broad list. And I would say, we talked about fungal infections and the halo sign, which someone asked in the chat. We did not see the halo sign on this CT. But there's other infections that can give you nodular appearance. So things that I think of are nocardia, which can happen in people who are 40% of the time. That happens in folks who are immunocompetent. Mycobacterial disease can do it. If someone has had the right exposure, rhodococcus, there's a few infections that can give you that appearance. There's inflammatory things that can do it. So thinking about granulomatosis with polyangiitis, or rheumatologic conditions that might give you rheumatoid nodules in the lung, inflammatory things that do it. Malignancy, both primary malignancies and then metastases, as these were. And again, I'm glad we had the former imaging to compare. Someone put in the chat, cannonball. That's usually what we see with Mets in the lung, is these very smooth, well-circumscribed, perfectly circular lesions. And this was a really good example of very irregular lesions that ended up being Mets. So I would say there's actually a pretty broad differential for nodules, even if you're not immunocompromised. It just gets longer and longer the less of an immune system you have. And I will agree with Laura on kind of that the humbling point of folks with bad cardiac disease. They can actually compensate really well, and they can be in profound shock even though they're not hypotensive. I have been fooled many a time by people who have a blood pressure of 110, and I think, oh, they're okay. And then they have what you described, which is a left ventricle that is just not moving at all, and they actually end up needing mechanical circulatory support in the end. So it's really good to keep that differential broad.
Amazing. Thank you so much for sharing all this. And Dr. Mira John, you have something that you like to share with us about this case that you learned?
I will echo the other points of never underestimate very severe and sudden onset cardiac disease or cardiogenic shock. I too have been fooled by this in the past. And also, again, differential for someone with immune compromise is broad, but again, like having a systematic approach to it. The differential, there was one differential I was thinking about, but then once we heard, oh, history of mesothelioma shifted to a different direction.
Amazing. Thank you. Thank you so much, Dr. Laura Granados, for this case. Thank you, Dr. Basak, Dr. Mira John, for being with us. We really appreciated the discussion. It was amazing. And yeah, I hope to see you all soon here on Rafael Medina Subspecialty on Monday. And yeah, thank you, everyone. I hope to see you all on tomorrow.
Thanks for having us.
Thank you.
Thank you all.